guys, you are going to want to listen up to this one. If you grew up in my generation or older, you probably didn't get a lot of information given to you about your body. You probably had to ask a friend or read an article in 17 magazine that gave you a very one-sided piece of information as your answer. Nowadays, yes, we can Google just about anything, but if you Google the same question enough times, you're likely to find 5 different answers that all promise to be right. When I had a fibroid removed earlier this year, the questions and comments about it in my DMs were insane. It was then that I realized how many women have questions that they can't get an answer to, or they're getting an answer that they aren't happy with. I thought, how great would it be if we could have an OBGYN to answer our most basic and intricate questions on everything from puberty to menopause. Because if you think about it, the same generation of women who had limited information on their own bodies are now mothering girls. And how do we feel equipped to share with them if we still are uncertain ourselves? When I tell you I could have asked her questions for a whole other hour, I could have asked her questions for probably another 3. When we finished, I knew I would have to have her back, and lucky for us, she agreed. So I would really love your feedback after this episode and let me know what topics you would love to see her come back on to speak about further. I was so thrilled she took time out of her busy day to answer our questions. I hope you get some great information as your takeaway from this. So without further ado, let's get to it. Here's my conversation with OBGYN Dr. Kristin Daniel. Today I have Dr. Kristin Daniel, who is an OBGYN, and I'm going to give them just a little bit of your background so we know who we're listening to today. And I will just put this out there and then you can tell me if I've forgotten anything. So you said you spent most of your time growing up in Florida. You moved around a lot of time in Florida. Mm-hmm. You did your undergraduate in Chattanooga, Tennessee, and then you went to med school in California. You did your residency in Ohio, and then you came and settled in Nashville in 2015. Correct?
Yes.
Is about that right? Okay. Did you always know you wanted to be a doctor?
I think that was probably pretty clear by high school.
Okay.
I don't think necessarily before then.
Did you like science? How did you know you wanted to be a doctor?
I mean, yeah, I was always kind of better at, say, science and math. That interested me. Problem solving was, I was sort of a geek that way, I guess. And I have several family members that are medical. So I had, some peripheral exposure that sort of made me wonder, at least.
Did you always know you'd be, when do you decide you want to be an OBGYN?
Yeah, that didn't come till med school. I really thought I was going to be a pediatrician. I was always pretty kid oriented as a kid. I was the babysitter, I was the summer camp person, all that stuff. And so, in my head, my interest in health and medicine and then my natural inclination toward kids made sense. I would be a pediatrician, but rotations in med school sort of changed my mind. I didn't hate it, but I didn't love it like I thought I would.
When do you have to pick your focus?
You generally, it depends on the med school now, but because they've changed some of the ways I think that they address this. But for a long time, it was more, you really don't settle on anything until your 4th year. You're hopefully exposing yourself to different specialties in your 3rd year rotations. In the type of med school education that I had, you don't really get clinical until your 3rd year. The first 2 are classroom, mostly lectures and stuff, some labs and things, but you don't go to the hospital floors until your 3rd year. And it's, a couple months in this, couple months in that, you're just trying to get your feet wet. And by the middle of your 4th year, hopefully you figured it out, because for the civilian match, and I say that because I was in the Air Force, but for the civilian match, that's in March, April. So you better, you hopefully figured out what you're going to try for by then. For us, it was a little sooner. They paid for my medical school education. So then I had to do, basically it was year for year. So they paid for med school. I owed them 4 years as an OBGYN in the Air Force. That's kind of how the military branches staff certain specialties that they wouldn't otherwise get. Yeah.
Gotcha. All right. Well, you ended up in Nashville in 2015. Mm-hmm. And there's not really an easy way to segue into this. So without further ado, let's just talk about vaginas. It's just what we're here to talk about today. When I first thought about doing this episode, I knew I wanted to do this, and I originally thought we'll just do it on menopause because really that's kind of the stage of life that I'm probably going to enter into next. Well, hopefully. And then I just thought there's so much more before that. And the women listening to this today, hopefully, are going through way beyond or way before that. And then also have daughters who are coming up into puberty and all those kind of stages. And just to really make this an educational hour for everybody. You and I actually met because you are my OBGYN. And I only, 6 months ago, maybe, I met you.
Yeah.
So I was talking on my Instagram page about having a fibroid removed. Dr. Daniel is who actually removed my fibroid. And when I said it on Instagram that I was having it done, I really thought I might get one person that said, well, yeah, I've had that done too. And the response was amazing to me. How many people said they'd gone through the same thing. Nobody was talking about it. They were asking me all these questions like, should I get mine removed? How did you know? Is it safe to keep in? And I was like, oh my gosh, I have no idea any of these answers. So that's why I just hope today is kind of a informational session to make people just more aware about our bodies, about our daughters' bodies, and really just kind of demystifying all the kind of heebie-jeebies that people get worried about. Okay, so let's start at the beginning.
Okay.
Let's start at the beginning with, I look at this as from like a mom's perspective. I don't know how many 9, 10, 11-year-olds are going to listen to this. But as a mom, for those of us listening out there, what age do we think is normal, average, expect our daughter to get their period?
It's a range, has a lot to do with your own, genetic makeup, of course. In certain families, it's pretty common to start later. That seems to be more the 13-year-old kind of, in some cases even later than that, but you're starting to kind of fall off the curve after that point when we talk about averages. I think the national average, last I checked, was more like 10, 10 and a half. And then there are girls who start sooner. There are, if you think about it, like 9-year-olds. that's 4th grade, 3rd grade.
That's really young. Yeah.
Especially if, it's often not on that girl's parents' radar. Right. Her mom hasn't even maybe
talked to her about it.
Considered the possibility.
Yeah. When should we start talking about it then?
Yeah. I think at least hopefully before, whatever age you were, as a mother, you want to just think about the fact that as your daughter approaches said age, she's going to, somewhere in there, she's going to approach it, and maybe sooner than you did. Right.
Is there like a worry point of an age of like, okay, my daughter's hit this age and she still doesn't have it. All her friends have it. When should I be worried?
I wouldn't say worry necessarily, but I definitely see patients, they're brought in by their moms because they're 15 and they haven't really had much of a period to speak of. And it's kind of a natural, concern that a mom's going to have because at least she's looking for it. Though it doesn't always mean something's wrong. Often those girls are really thin or they're really athletic. Totally. If they have no body fat, it's going to delay a lot of this or at least get in the way. And often I'll have talked to them and they had one period, but they haven't had one since then, any stretch of 6 months, a year, whatever. But ultimately if they have other features of womanhood, namely breasts, yes, breasts and other things reassure us that, okay, the parts are there, the hormones are there. It just may not be the consistency of the menstrual cycle, which has to do with a lot of other things sometimes.
Okay. Is it normal when they first get it to be pretty like monthly, or is it sporadic?
I think for most teenage girls, it's going to be sporadic at first. It doesn't usually start and then just continue like clockwork from the get-go. And again, those other factors like, is she underweight? Is she overweight? What kind of healthy diet does she have? Is she an extreme athlete or not? That's going to play into how sporadic or consistent they may be as they get going. And sometimes I think it's just purely DNA.
Right. Like if you were the same.
Yeah. Or grandmas, aunts, all the women count.
Right. If someone were concerned about their daughter's cycle, do you ever put them on, like, is there ever a concern is there a benefit to having a regular cycle, I would say? Like,
there definitely is. For one, predictability, right? She doesn't want to be surprised no 15, 16-year-old girl wants to be surprised with a period in school.
Yeah.
As a pure example. Or younger, right? It's worse when you're younger,
Right.
I think. Middle school boys are...
Yes.
I have one, so I can say that.
Yes.
But, they know even less.
Right.
So and at least by high school, some boys have some kind of knowledge base. So yeah, from the pure I want to know when this is happening. I want to be prepared. Predictable is nice. And if you're not predictable, that's one very common reason as physicians, we're going to offer / suggest birth control. There's absolutely nothing wrong with that.
But at that stage, are they taking their daughter to their own OB, or are they taking them to the pediatrician to ask about that?
It goes both ways. I've had patients referred by their pediatrician after mom took them there. And I've had them just come directly to me. Maybe the mom is my patient. Maybe their friend just recommended me because somebody they know said, go take her here, or it's just our practice reputation. And I just happen to be the next on deck for a new patient. I mean, any of those is fine.
And it doesn't mean, though, that they're coming for a pap smear, right?
Right.
Okay.
Yeah.
Which
so
I think a lot of people are worried about.
Absolutely. As a teenager, I would have been too.
Yeah.
So newer recommendations for all the moms out there, it's age 21 and not before for any reason.
Wow. Okay.
I get referral. I get patients all the time whose moms have said, you must go, you must go, you must go. You're 18, because it used to be 18. It was actually 18 or within 2 years of first intercourse. So for some, it was younger. But now it's 21, no exceptions.
No exceptions, even if they're sexually active.
Yep.
Why is that?
Because the studies around HPV and abnormal pap smears and how that evolves actually showed that it's really common in your first few years of sexual exposure. It's really common to have HPV virus and even abnormal pap smear changes that are going to then resolve in the next few years. Because most of those will resolve. Most of them do not turn into the precancerous changes we're looking out for. And even if they do, it's a 20 to 30 year march on average. So we have plenty of time to look, namely 21 and after, even if she's had sex. The other one they always did is if you were pregnant because you had sex.
Yes.
But, I've had some of those too, like outside referrals, somebody papped her even though she's 18 because she's pregnant. I'm just like...
Is there a risk for doing it too young, or just like the abnormal test
so
results?
The risk is the same for all the ages. The issue was over-testing leads to over-treatment. You feel compelled to act if you find an abnormality. I can't look the other way if you have an abnormal pap smear. Oh, but wait, we can. Because of what we know, those low-grade, especially those low-grade abnormalities, are likely to resolve in the next couple of years if you just leave them alone. And so that's where they came up with, we're just going to move this age guideline to 21. So then that brings up, if I have a patient who comes and she's 24 and all her friends are like, what do you mean you haven't had a pap smear?
Yeah.
Turns out some of those girls haven't had sex yet. Good for them.
Okay.
And I have a hard time even then. I'm like, yeah, but what am I looking for?
Why are we doing this? Okay.
Because the common, and I may differ, honestly, if I'm being totally honest, I probably differ in this opinion from a lot of my colleagues because doctors, and I'm this way too, we tend to be very risk averse. And what's the risk of not looking? Well, the risk is she might have some rare thing that I would otherwise catch if I looked. But you're talking about rare things. They're even like less common in a young woman than an older woman. And furthermore, and this is my baseline argument for this, is the pap smear screening is to detect the common types. So you can have a pap smear every 6 to 12 months. We used to do them every 12 months. You can have them be normal, and then that woman next year has the weirdo rare thing because we can't look for that. We can't see that one coming. So it goes back to my, I'm like, if you're 24 and you have never been exposed, what am I screening for?
I was going to ask you that because I know for me, up until recently, it was always the guideline was every year.
Yeah.
And now it's switched to, is it 3?
Well, first change was 3, second was 5.
It's 5.
Yeah, 2010, it was 3 years. And I think it was 2014 they changed it to 5.
Why 5?
Well, same data sort of being recrunched, looking at a longer term follow-up of the same study populations, and based on the co-test. So we don't just do a PAP anymore. We do a PAP and an HPV viral test. And so it's a 2-footed test. It helps us be more specific. We're not missing as many things as the pap smear. The pap smear, part of the reason we had to do it so much is it only sampled like 60 or 70% of what was there. So you had to do it frequently to eventually catch the whole thing, right?
What is HPV?
So it's a virus.
That don't know.
Yeah, there's probably hundreds of them. Kind of like there's lots of mutations of flu viruses and coronaviruses. Anyway, lots of viruses that can affect the cervical cells and cause genital warts. That's a sexually transmitted infection that won't necessarily result in an abnormal pap smear. But there are high-risk types that can, over time, alter the DNA of the cervical cells to lead to cancer.
Okay. And how does one get HPV?
Sexual exposure.
Only?
Mm-hmm.
Okay.
Yeah.
Does condoms prevent that?
Definitely better than nothing.
Okay.
I think condoms do a lot more than we give them credit for.
Okay.
They love to say things like, however teeny tiny the holes are between latex or some non-latex condom, latex is better, the holes are smaller. That can prevent, we say it can prevent HIV, right? And it does. The issue with condoms is people don't use them. Turns out if you use them, they're pretty effective for most things.
And I'm no doctor, but I am going to go out on a limb and say that the pill, an IUD, no else there is, the ring is not preventing HPV.
Right. I have to remind people all the time, this is birth control. This is pregnancy prevention.
Yes.
This is not sexually transmitted infection prevention. That's where the condom comes in.
Yes.
And the condom doesn't cover every point of contact. Therefore, sometimes there is sexual transmission of infections outside the point of contact.
Okay. And I actually asked you, I didn't realize when I was looking this up, that they are no longer referred to as STDs anymore. They're STIs, which is sexually transmitted infection.
Right.
And you said it was because...
Well, it's a trend. I think just in general, we started using words that are maybe less... I don't want to say offensive, but people don't want to think they have a disease. Disease implies chronic.
Yes.
I'm never going to
infection can be cured.
And infection is, it's a less dramatic word. I think that's the trend. Terminology matters.
Yes. Okay.
Old terms need to sometimes be replaced by more accurate ones.
STI is what we call them.
Yeah.
Okay.
But if you say STD, everybody knows what you mean.
Yes.
Yeah.
Most common that, I don't know if you can say what you see, but most common that...
I don't know if it's gonorrhea or chlamydia. I'd have to guess probably chlamydia more so. But
really?
Those are still, pretty much. Those
treatable?
Have kind of always been. Yeah.
Treatable.
Totally.
See your doctor.
Yeah.
What are, I don't know if I want to ask this question.
For everybody, I get so many patients who are, my nurse will check them in and ask them if they want to have STD screening. It's recommended for women up to the age of I think it's 28 or 29 now, just routine. If you're sexually active, you should be screened at least once a year. A lot of women declining.
Why? Because they just don't think they have it?
Yeah.
Or they don't want to know?
Because they have no symptoms. And the important thing is, especially those two and others, are asymptomatic.
I was just going to ask you that. There's no symptoms of either? Chlamydia, gonorrhea?
There are more symptoms for men than there are for women.
Oh, okay.
The problem is we're talking discharge, right? So for men, that's abnormal.
Right. For women, you can just think it's anything.
There's a baseline vaginal discharge that is normal, and so it may not look or, it may not ring any bells for her. So,
how do you treat it if you have it?
It's just antibiotics.
And if left untreated?
It can make you sterile.
Oh, wow. Both?
Both infections? Oh, yeah. And others. But pelvic inflammatory disease is kind of where it has climbed up in there and wreaked havoc on your innards. And sometimes that's acute abdominal pain.
Okay, I was going to say, you'd be feeling it by that point.
Get admitted to the hospital.
Okay.
We give you antibiotics and we hope you're not sterile later.
Wow. Okay. So STI screening is different from a pap smear?
Yeah.
Or it can be?
It can be run on the same test.
Okay. But you could just have the screening.
I can do one test and run several things on it.
So if you only need a pap every 5 years, though, you could still, if you're sexually active, be having the STI testing.
Right. And you bring up a good point that needs to be made. When these guidelines have changed from pap smear every 12 to pap smear every 5 years, 12 months, 1 year to 5 years, we're not saying the visit. And patients hear this all the time because everybody referred to the annual visit as the pap. Right? It wasn't. It was the annual visit, at which time you also had an annual pap test. Now it's an annual visit. Sometimes you need a pap. A lot of the times you don't.
Okay. So we still need to be coming to see you once a year.
Yeah.
So I guess when do you decide if you need the STI screening? If you're kind of
serial monogamy.
I was going to say, if you're if you're not worried.
Serial monogamy does not protect you from infections. And two well-meaning people can bring things to a relationship that they didn't even know they had.
So should we all be getting it every year?
Pretty much. My recommendation is probably before a new relationship that, becomes sexual and maybe soon after it has. to make sure. Because the price is pretty high if we're talking pelvic infection and sterility, you know?
So if we're not having a PAP at every visit, what are we doing at the
Well,
annual?
I was joke, but you're more than a cervix and I'm more than a cervix checker. People like,
it's good to know.
They think that's the only thing I do or something.
I know. Well, I think for so long that's what you did. You're like, I'm booking my annual, and that that's what it means.
It was like, got to get the cervix checked. Who cares about the rest of it? I mean, you have a uterus and ovaries and hormonal issues, maybe. I hate that word, but we can get back to that in a second. Period problems, vaginal discharge problems. Annual visit is a time for us to ask some pointed questions to make sure you're normal. Because some of you don't realize that what you're experiencing, absolutely, breast exam. That's my other thing, like, okay, maybe your cervical risk is becoming less and less as you age, but your breast risk is becoming more and more. And who else is checking them if it's not me?
Right. You're trusting
Some
themselves.
primary care doctors will do it for you if you ask them, but a lot of my patients, when I say that, they'll be like,
no, I don't want them to do it. Yeah.
Primary care doctor.
Okay. Okay.
Yeah. Well, then that's what we're here for.
What age are you sending women for a mammogram now? Is that changed?
No, not really. The screening mammogram age for the general population is 40. And for a long time, it was not really questioned annually after that. Then there were some studies came out. The U.S. Preventive Service Task Force brought it up that maybe it's not super useful to do it annually between 40 and 50. When I say super useful, they mean the cost to the healthcare system on the whole of screening asymptomatic women annually from 40 to 50. They weren't picking up a ton of asymptomatic cancers for all the extra mammograms that we do. That is different than a lump being found by the doctor on an exam or a lump being found by the patient in their 40s. That happens quite a bit. We're purely talking about the people who had 0 exam findings and went for their mammogram and an early breast cancer being found, in that decade. So there's this big thing, like maybe, it was caused like a media fuss because the breast cancer, Susan G. Komen Foundation was all like, what? No, we cannot, don't say that. And a lot of people know a person who got diagnosed with breast cancer in their 40s, right? The American College of OBGYN has kind of stuck by we say every 1 to 2. Officially, it's said every 1 to 2 now that I tell my patients every year.
If you have, you say every year. Mm-hmm. Okay. If you have, if you're high risk, if you have like your mother or earlier.
Well, one person in your family tree is the statistical average.
Okay.
So having a mom or a grandmother, sister, whatever, doesn't necessarily mean you're in a high-risk family tree. Now, if you're, 1 degree of separation in the tree, that can feel really close to home. And a lot of doctors would order something early, and there's nothing wrong with that. But, the risk for breast cancer, we used to say 1 in 9, now we're saying 1 in 8. So I don't know if we're rounding up or down or we're just finding more. But it's high. If you do that math, that's ridiculously high. So everybody's got one in their tree at some point, pretty much. If we're not talking your DNA line. We're talking 1 in 8 women. So that can be the women who married into your family. Like, you don't carry their DNA, right? But there's generally 1 in every tree. So when you talk high risk, you're talking like, do you carry the genes that increase your risk? So BRCA is the famous one. It's still probably the worst. There's BRCA1 and BRCA2. They're still probably about the worst risk that you could
carry it.
Mm-hmm.
So if you have
there's like 50 other genetic cancer genes that they are tracking and looking for in high risk families.
When would you recommend someone get the BRCA testing, or would you?
Yeah, when patients come and talk to me about their family tree and elevated cancer risk, I generally recommend that I send them to a genetic counselor because that can be the most helpful. Because if I just order a BRCA test, I could have missed the one they really needed, right? It's the buzzword. It's the one everyone's heard about, but
so a genetic
it's not the only one out there. Yeah.
Okay.
And so if we have them go sit down with a genetic counselor and they can, the more people who had what type of cancer, which relationship they were to you and all that jazz, then the geneticist can be a lot more helpful with you do or you don't seem like you're in a, high risk family. And then from there, make recommendations on you should be screened for all of these. I find that it also maybe helps, insurance cover the test if the geneticist deems it warranted. If I just order something, they may say, yeah, we're not paying for that. So this way the patient gets a lot of information, about her own potential risk. The geneticist can answer all those questions a lot better than I can, and then recommend what test they should get. And then the last thing I tell my patients is they may look at your family tree and say, plus or minus, get these tests. Let's say your tests come back negative, but your family tree is really suspicious. Then they do have increased surveillance plans that they'll still put patients on. Like, yeah, we know you didn't test for anything, but your tree's weird.
So we're going to
have you do early mammograms.
Okay.
Or some patients are on like alternating mammograms and MRIs because,
they've got so much in their family.
They've got some sort of suspicion. And MRIs are expensive and really hard to justify to insurance if I'm just ordering stuff. So that's, I get that kind of letter on their chart that says the breast specialist recommended this, and honestly, around here, it's great. We have a lot of really great breast doctors who just sort of take over that whole angle. They'll just keep them on the surveillance plan and follow up. And then, it almost doesn't even involve me anymore other than I get the reports too. Yeah.
All right. I wanted to go back to one thing when we were talking about periods, because I think a lot of women, and I just know like from having friends who have daughters, it's always that, when's my daughter going to get her period? And we talked about that it was, genetics, and think about when you had it. But talk to me a little bit about knowing like the onset of puberty and when you, like, what would be the first sign you might notice as a mom, and then what you're looking for in terms of like from there out.
Right. So, the simplest thing, we talk about breast buds. You said you don't like that word.
The word.
I don't know. Word. And then buttons. The second page
buttons.
Is the
you
button.
said the buttons, and the buttons might be worse than the buds.
I agree.
Yeah.
I agree. So there's, a mound of breast tissue sort of shows up first, and then the nipple area pops out from that.
Okay.
And then eventually it all becomes one contoured breast.
That's the first sign of puberty.
So yeah, officially the breast growth is, well, I'm not going to say that's the first sign. We all probably get the hair in the armpits and the pubic hair area first, and that's boys and girls about the same phase. But from the breast development, once you've identified that, about 2 years later, you can expect her period.
Okay. You be on the lookout for that.
Right. It's kind of your warning shot.
Okay.
Yeah. Now, it's not like your girls that age are probably not exposing themselves to their mother's gaze very often.
You have to be on the lookout, yes.
You may not notice. You may be a few months behind by the time you notice. But if you have to buy your daughter a training bra or whatever they call them now, you're on notice.
You're on notice. Yes. 2 years. Mark it down.
Inside of 2 years at that point, because
because it's too late.
It's been a few months. Okay. And you don't know how many.
And then I feel like I have heard so many different versions of, people will say, well, your child is done growing from X amount of time from the time they got their period. Is that true?
Oh, I should know this.
Someone said it was like another 2 years from when they get their period.
Yeah. In general, one of the questions I'll ask when my teenagers come, the mom has brought them because their period's weird or isn't, I'll kind of go through like, well, we have normal breasts, do we have hair, do we, and how tall are you? In general, within their growth spurt is all kind of in that time from breast to period. So generally by the time they have their period, a lot of that has happened, not necessarily all of it, especially the poor girl who starts at 9, right? She might be taller than her friends, but she's probably not done. So yeah, roughly a couple years after that, you've pretty much finished growing.
Gotcha. Yeah. Okay. That's, see?
There are all kinds of stories about girls who have grown 1 more inch at like when 19 or something, and that's unusual.
But the normal is, okay. Mm-hmm. All right. So we've gone through puberty. We have gotten our periods, and we're maybe getting to that age or stage in our life where we've now started seeing an obstetrician or an OBGYN, and all of a sudden you have a young lady who wants to not be pregnant. So what, if someone comes to you and says, I've never been on birth control, I want to be on birth control, I'm sure you've heard all these people who have said, well, I've heard the pill does this, or I don't want this, or I want to be as natural as possible. And
I'm not a fan of Dr. TikTok.
And it probably is a lot of TikTok.
Yeah, a lot. Yeah, it used to be Dr. Google. Now Dr. Google doesn't sound so bad.
No, yeah. What's your first, like, someone who's never been on birth control, never had a reaction, what's kind of like your go-to? Do you have a go-to first suggestion?
I try to get a sense of where they're coming from because, there's a lot of misinformation and they can sometimes have, erroneous opinions based on what they've heard and that information wasn't actually factual. So And on the other hand, a lot of girls will come and they know what they want because their friends are all on something. And they're just like, I just want to do that because it worked for them. And that's a reasonable approach too. We just have to talk about, risks and benefits because we have to do that about everything. But the pill is very widely used. It's the most widely used birth control there is. The pill, there's like hundreds of them. They vary slightly in progesterone component and dose. There's only a couple different doses. We start on the lowest because the lowest works for the most people without much issue. And then we go from there. If it's not quite getting us the results we're looking for, we adjust based on what the feedback is.
What's like the number one complaint you would have with someone on the pill? Or is there like one major one, or is it different?
I think the problem with pills, as with any medicine, you have to swallow. I say this a lot to patients because they'll say, I can't take birth control because
I have to swallow a pill.
No, they'll fill in the gap with because it made me crazy, it made me emotional, they'll say it made me hormonal again. I hate that word. Or there can be some other things like it made me nauseous, whatever. But when I drill down, most of those women have only ever tried a pill. Okay, and it's not the hormones. Everyone thinks it's the hormones. You have hormones in your body. If you're a functioning woman, your ovaries already flood your body with more hormone than I can give you ever.
Okay.
So it can't be the hormones in the pill. At least not purely. And my theory is it's the binders. It's the stuff that your body has to break down, absorb, circulate, molecular stuff that is telling your body where to take this medicine so that it'll do its job. And that's unique to anything you have to ingest, right? Antibiotics, people understand, there's lots of different side effects from antibiotics. Those are mostly oral, right? So I talk about that with patients a lot because if they've had a bad experience with birth control, usually it was a pill. And some of them don't even know that there's like this whole other range of options that they don't have to eat.
Yeah.
And really then much less chance of side effect because you don't have that.
Like an IUD?
Well, that's the other end of the spectrum, but yeah.
Why is it that just because it's like an actual object?
Well, it's the lowest dose and the longest use. It's the easy button. I talk with my hands. I'll tell my patients there's a breadth of options. The pill is the least convenient, most likely side effects. Though I will say most women take most pills just fine and have, it's probably 1 in 10 that's even really going to have any of these side effects we're touching on. But as a option, pills are the most side effect prone,
right?
We'll say. They're also the least convenient. You got to take it every day. If you forget, there's more high stakes there.
What happens if you forget?
Depends on what time of the pill pack you're in. If you're right before your period, you're fine.
Okay. Which is end of the pack? I don't know.
Right before the placebo color of pill. Most pills will come in 3 weeks of one color and a week or 4 days, 7 to 4 days of placebo. If you're toward the end of the active pills, you're already you're clear. Okay. So if you miss the last few, that's not as critical. One of the last few, hopefully the least number of pills you miss, the better. At that point, when you miss pills, it's more likely you're just going to have your period early or something, but you're not risking pregnancy. The very beginning, for the most part, if you miss the first pill by a day or something, that's probably still okay. It's the middle that's an issue.
Because that's when you're ovulating?
That's when you would if you don't take the pills to suppress it. Yeah.
Okay. And even one miss?
For some girls.
Wow. Okay.
Yeah. I'd say most of us, unless you miss the day before your ovulation, and this depends. Longer term use has shut that down more reliably than someone who's just getting started.
Okay. So you said IUDs on one side of the spectrum, the pills on the other. Right. What's in the middle?
Right. So pills are 1 a day. Then you have the patch. That's a lot of people don't know about it. It's great. It's what I talk about with my teenagers all the time. It's like a Band-Aid square, and it goes on your skin. The catch is it has to be over a muscle. So because that's where most of the bloodstream is muscle tissue is very vascular. Fat is avascular. We want to get directly into the bloodstream as reliably as possible. So that's the catch. Can't be on your breasts or your bottom, but it can be anywhere else you want to put it, pretty much. And it's 1 a week. And so you wear the Band-Aid square for a week. And yeah, pretty much. If you're like an Olympic level swimmer, you're probably not going to be able to do the patch.
Could you shower with it though?
Yes.
Okay.
Yeah. Normal wetness activities is not going to make it fall off.
It's just putting hormones into your bloodstream
right. So pretty much the dose you need is in every square millimeter of that thing. Huh. So even if the edges come loose like a Band-Aid at the end of the week, you're still getting what you need.
So that's your go-to recommendation.
Well, I talk about pills and patches with the teenagers probably the most.
With teenagers.
Because they're scared of everything else. A lot of them haven't had sex. They can't fathom putting anything in there. I totally get that. And then there's a shot.
Okay.
Shots are not popular because
they're not.
shots.
Yeah.
And for other things.
Okay.
The shot is 12 weeks. So it's quarterly.
Do you give it to yourself?
You can.
Okay.
You can be taught to do that. A lot of our patients come and get it at the office. They just make a quick, arrangement with the nurse through the system, and they just get their shot and go. Some get it at the pharmacy, right? So a lot of these pharmacies have like a provider there that can administer these things on site, and so they'll just do it that way.
Okay. What's your favorite for like a mom who's had a baby and not trying to have another one,
That's
or
where
wants to have another
I really
one?
talk about like IUDs a lot, or say like the NuvaRing is another more. If I categorize them as local delivery versus systemic delivery, we have pills, patch, and shot that are more systemic exposure. So let's say we took her off a pill because she had side effects that I was pretty sure was just the pill, the ingestion. She goes on the patch, but now she's still having, say, migraine type headaches around her period. These are all very uncommon things. I'm just, if she just, whatever, the patch wasn't her bag. The shot is sort of off my tier. It's just an alternative that some people love and lots of people don't love. But then we moved to local delivery. So that means we're not sending it through all of you to get here.
Right.
We just put it here.
Just right in there.
Right. So the NuvaRing, it fits in the top of the vagina.
Okay.
So I was telling my patients, if you can wear tampons, you can figure this out.
Oh, wait, you got to put it in yourself?
The patient puts it in.
Every day?
No, it's one a month.
You leave it in for the month?
Yeah, it's one a month.
And you don't feel it?
No, but that's the whole thing. You don't feel a tampon if it's properly placed.
I guess.
Yeah.
I feel like those probably are not that popular. Are they?
There's a handful of people who really like them.
Okay.
But yeah, it's not, I wouldn't say nearly as widespread.
I had an IUD, and it's like once it's in, it's just...
Yeah, it's the easy button.
Yeah.
Yeah, so the NuvaRing, to contrast, it still works a lot like the pills in the patch. You have 3 weeks on, 1 week off. That's when your period comes. So officially, the NuvaRing is in for 3 weeks and out for 1. Now, there's a new variation of this called Anavera. It's a year. You just use the same ring. So it's 3 weeks in, 1 week out, 3 weeks in, 1 week out, same birth control the whole time. Rather than these, the NuvaRing, which was the first.
Yeah, I feel like I've heard of that. But
right, is in individualized kind of foil packs, 1 per month. Yeah. And then you have the IUD, which is only progesterone. So now you don't have the cyclic month to month, like recreation of the period cycle. You like the shot, and another thing we haven't talked about, the Nexplanon, which goes in your arm. The shot, the Nexplanon, and the IUD are all progesterone only.
What is the Nexplanon? What is that?
So that's an implant. We inject it right below the skin.
Okay.
And
how long does that stay in
feel
for?
It 3 years.
3 years.
Mm-hmm.
Wow. Is that new?
Last decade-ish.
Okay.
I mean, I trained on it in residency, so I guess officially it's older than a decade.
Okay. Yeah. Can you just get it out easy if you...
Well, I mean, we have to remove it.
Yeah.
It's kind of
You're not,
scarred
like,
under your skin. Yeah. You can't pick it out yourself, I don't think. You have to get some sharp
But you could get pregnant right away.
Yeah.
When you have it taken out.
Right.
Okay.
Yeah.
Which I think was great for the IUD, is that they said you literally can take it out and be pregnant the next month.
All the birth controls that I'm talking about, except that shot, are immediately reversible, which means as soon as they're out of you, your body starts doing its thing.
And the shot, you just have to wait that time frame.
Yeah, the shot is a 12-week thing. So it's kind of like a vaccination. You put it in the muscle and it sits there and slowly leaches into your system over time, which is why it's effective for 12 weeks. But the problem is everybody's body metabolizes this slightly differently, moves it around slightly differently. And the longer you've been on it, the more extra you have, right? So you could theoretically have been on it for a year or two and not gotten your last shot, you went your whole 12 weeks, didn't get your next one. It's not like your period's going to come back the next month. There's often extra. So the longer you've been on it, sometimes you're waiting 6-9 months for it to get out of the way so you can...
How do you know you didn't metabolize it quicker than normal?
Well, the cutoff, the 12-week cutoff is cut below all that. Like when we do those studies...
So that's your safe spot.
Yeah. Okay. Like the IUD was originally only approved for 5 years, the Mirena with the progesterone, and now it's 7 because they went back and did a new study because we were all pretty sure it lasted longer.
Was approved for 5 years.
Yeah. And so when they made that 5-year cutoff, they did it based on the number of people, we're picking a number, or we're picking a place where we didn't have any oopses, reliably related to the hormone level was not high enough in these girls, because you don't want like like widespread pregnancy failure.
Yeah,
that would be really
right.
bad.
Okay, perfect. Okay, so speaking of pregnancy, we are now not wanting to be on birth control anymore.
Okay.
And we are wanting to have a baby.
Yeah.
I know, I'm sure everybody in their life has heard the ideal time to get pregnant. Don't wait too long. You better freeze your eggs or you're super fertile.
Yeah.
Is there truly an ideal age to get pregnant?
Well, I mean, yes and no. Your most, let's say your most fertile years are, I mean, the starting point, I think we could debate that all day long. But I mean, officially, once you've had a period, you can get pregnant. I don't think anyone should.
Yeah. Let's hope not.
Like, it's a problem with some historical issues we have there. But anyway, goes all kinds of different directions with that.
That's another episode.
Yeah, totally. So, you know, prime fertility is probably more like, we'll say 18, 20, 21, somewhere in there. Like, not that people, and in this, the generations behind us have really turned that on its head. They're not getting pregnant that early. I totally get it. You know, it's career first, babies later. Why not? You know, and that's just gender roles are changing and all that other stuff. That's probably a good thing. Back in the day, lots of women got married that early. Yeah. And, or didn't, they just got pregnant at that age, whichever. That is prime fertility age. It doesn't mean you need to do it, you know, age and stage, whatever. But the upper end of that, then when we're talking prime age would be 35, 34, because 35 and up is elderly.
Yes. I was elderly when I had Ava. I was 36. Yeah, elderly.
I still call it advanced maternal age. That was the original code.
That's what I was, advanced maternal age.
Yeah, the codes that we had to move to, which are in line with all the World Health Organization codes, are now, you know, it's elderly prima gravida.
Elderly sounds like a senior citizen is having a baby.
Yeah, that's a little overdone.
I mean,
it's much.
Yeah,
it's a lot.
Okay.
So, I have patients all the time. They come in, they're 32, and like, I know I'm old and I need it. And I'm like, stop.
Right.
First of all, you're not old. You haven't met any of the criteria we're even talking
32.
about.
Yes.
And second of all, the 35 is, I mean, it's based on statistical age-related increases in the complications of pregnancy and chromosomal issues that lead to, say, miscarriage or Down syndrome. That stuff it climbs every year.
Why? Like, what in our body makes us more prone to have, I mean, you're saying miscarriage or abnormality in a pregnancy as we age? Like,
I mean, because the older we get, the less well our body works.
Is it the like health of our eggs?
Well, and then there's that. Yeah. Okay. So, like, I mean, the rate of attrition for usable eggs is obscene. Okay. It's like somewhere in the billions when you're in utero in your mother.
Right.
By the time you're born, it's down to the millions.
Okay. Which makes perfect sense.
By the time they're usable and you've gone through puberty, we're now in like the 100,000s.
Okay. And
by menopause at
0,
50-ish, 1,
negative
51.
Yeah.
You're out. So, I mean, you're losing them faster than you can release them and use them.
Okay.
Yeah.
So you and I were talking about this before. Egg freezing. What do you call it? Egg freezing or
sure.
egg?
Preserving your eggs for one day in the future.
Right. I feel like I've seen a lot of this. I don't know anyone that's done it, but I feel like I hear a lot about this like on TV shows or things like that. And they'll talk about, well, I'm going to freeze my eggs because, you know, I'm 31 or I'm 32. And what if I don't meet somebody? Is that a smart thing to do once you hit a certain age?
I mean, probably depends on how much money you have to do so.
It's expensive.
Most fertility treatments are. And I'm not going to claim to be a fertility expert. We have a whole subspecialty of OBGYN. That's all they do. And they could answer, you know, data questions a whole lot better than I could. But, you know, we've gotten pretty good at freezing and thawing sperm. And every time you thaw something, well, freezing or thawing, you're compromising some of the cells, and you won't get them all back. But because there's so many sperm to begin with, we get a lot back. Then, you know, IVF and embryos, so sperm, egg together, started to make an embryo and was frozen at a certain stage, then is thawed and put into the patient to conceive. They've gotten a lot, real good at that. We're doing like single embryo transfers now. Back in the day when this all started, they would put like, you know, 4 in the person and hope we got 1, you know. So they're getting a lot better at that. But the final frontier is kind of the egg freezing. And my understanding is eggs are a lot harder. Well, first of all, there's not very many, right?
To get out at a time.
Right. You gotta give this woman medications to help her ovulate more than one
Right.
in a month. Because normally we're just
You're just having
releasing
one a month.
Yeah.
Okay.
Except for those families that have twins a lot. That we can touch on that later if you want to. But yeah, if they are, if they're only going to put out one and you're trying to get more because she don't want to do this for months and months of egg retrieval. So you might get a few and you might do that for a few months to get a handful of eggs. But then you freeze them. And my understanding is you don't get very many to survive the thawing. Yeah. And so that's sort of, I'll tell my patients like, yes, they're doing that now. My understanding is that Nashville Fertility Center is doing that here. I used to have to send people to Atlanta. But
so it's becoming more common.
It's becoming a thing. Okay. But then I tell my patient she needs to go over there and have a conversation with them about the cost and whether it's worth it to you. Because, somebody who's in her 20s, yes, 20-some-year-old eggs, but she's also got a lot of time, somebody in her 30s, that might be a totally different consideration or conversation. Yeah.
So we're off the birth control. We are not going to freeze our eggs because we feel like we are in that kind of stage where we should just be able to get pregnant.
Okay.
First month, are you just trying all the time? Do you need to be tracking your cycle? Do you need to be doing ovulation sticks? Do we need to do all that stuff? Or at the beginning, do you just try?
Yeah. Well, if you were on birth, let's just go from the girl who was on birth control and stopped it, right? She wants to get pregnant. Is her period going to be predictable? That's the first thing. So when a patient comes to me and she says, we're thinking about getting pregnant in the next 6 to 12 months, what do I need to know? This is kind of the spiel I give them. Stop your birth control. If your periods were regular before your birth control, they're probably going to be regular after. But if it's been 15 years, it's been 15 years. Your body is 15 years different, right? So I can't guarantee you your periods will be exactly the same. But if they're monthly, that's evidence to me you are releasing an egg monthly. Okay, so then the question is, where is it? How do I find it? The apps and things, everybody's head is built on a 28-day calendar. So our friends in high school who knew when their period was coming on the third Thursday of every month, they were the 28-day girl. And that is the average, but it is not everyone. Okay. The math there is real easy because the 28-day girl ovulates on day 14.
Okay.
The misconception for everybody else is that it's divided by 2. That is
it's not the case.
Yeah. So
I'm just out here sharing wrong information.
It's generally going to be 14 days from ovulation to period.
Okay.
So a girl who's 35-day cycle,
needs
she's got
to
the 5 week.
14.
So she ovulated more like day 21.
Gotcha. Okay.
Yeah. And a 5-week girl is not that common, but they're out there. Lucky them. And then there's 3-week girls, which means she ovulates a lot sooner.
What is the longest time your cycle could go? Like you said 28 is average. What's
So 21 to 35 is considered normal cycle intervals. It doesn't mean one girl's going to be all over that map, right? Regularity means within, one girl is within a few days every month. Okay. You can have a weird month. Everybody can have a month where they, it was a week late or something and their period was weird. And it doesn't always mean they miscarried. I get that all the time. People think that they miscarried because they're like clockwork and this one came 2 weeks late. But if you never had a positive, and even if, there's other things called chemical pregnancies. We could get into that too. Sometimes there is a quick positive that went away.
Right.
Those happen more than people
or
realize.
What's it called? Like a false positive or something?
Yeah, a chemical pregnancy, I guess, we're on it now. We might as well just cover it, right? But chemical pregnancy, it happens to people who aren't looking for a pregnancy probably way more commonly than we know because they weren't looking, right? Somebody who wants to get pregnant and takes a pregnancy test before her period, she could see a positive.
But what is tricking the test then?
It's not tricking.
Oh.
So here's the thing. If an egg and a sperm find each other on the way out the door, you're still going to get the hormone drive-by.
Oh. But you're not really pregnant?
Well, it tried.
Okay.
But it's going to fail because if they met too late in the process, it's already unsuccessful. The whole point is the egg and the sperm have to find each other at the right time because they need to implant in the uterus and not get expelled as the tissue starts,
So a chemical pregnancy
leaving.
is that they found each other at the wrong time.
Basically. A little too late.
And will be getting expelled at
Pretty
some
much.
point.
Yeah.
Okay.
But there's often a hitch, meaning, she's 2 or 3 days late or she's a week late. She thinks she's pregnant. Then she feels like she miscarried. If she hadn't been looking for if she hadn't been taking the test, she would have just been like, my period's late. She might have taken a test. By then it might have been negative because her period starts the next day. There's variations on that. It could be positive too. And then she starts her period the next, So, and we just kind of deal with that however the patient feels, and some of them are, they know that this exists and they're metered in their response and others are just devastated, and I mean, that feels like a miscarriage.
Because they thought they were,
yeah.
And it's hard to tell somebody you
to
weren't,
us, it's not really a classic
Yeah.
miscarriage, but if it feels like one, it is.
For sure.
You know, when you wanted a baby and you thought you had it for a second.
Yeah,
like,
then you're like, yeah.
Yeah.
Okay.
So, but it doesn't bear any future, I mean, I'm saying bearing twice. There's no future bearing on your fertility because you had a chemical pregnancy. Because the truth is, we probably do that a lot more than we realize. Anybody not on birth control, not paying attention to it.
Right. What's probably happened to you. When does someone come to you and say, I've been trying for X amount of months, and you say, okay, it's time for me to send you on to a specialist?
Yeah. Roughly, if you're normal reproductive age, so that 20 to 35, you know, you don't meet any criteria for, we used to say infertility. Now we say delayed fertility. So the terminology
Didn't know that.
had to change that. You don't want to tell someone she's infertile.
Well, right. It's not a great word.
No.
Yeah. Okay.
So delayed, meaning
Delayed fertility.
It's taking you longer than average. Accurate, right? Is 12 months without preventing.
So even if you got pregnant and miscarried, that's not?
No, what I mean is you could be having unprotected sex. You weren't trying.
Okay.
But if a patient tells me she's been with the same person for 2 years, having regular sex and no birth control and no oopsies, I'm already, my antenna are already up.
So something's, yeah.
The oops rate. That's basically what we're saying.
Right,
The oops rate.
Yes. How many oops rates? Yeah.
In 12 months of unprotected sex.
So then you would refer them on.
Right.
Okay.
So a person who was asking me, like, you know, how long should we wait? I mean, if she's trying, we mostly say 6 months. Right. The oops rate was 12.
Oh, if they're trying actively is now 6. Okay.
7 out of 10 couples will be pregnant by 6 months of trying. Some got pregnant right away. Some just got pregnant on month 6. Then roughly, again, not a fertility expert, so maybe they have different data now, but this has always pretty much served me well. 2.9 of the 3 remaining couples usually conceive in the second 6 months. Okay. Little say slower than average, but they got there all by themselves. Which is that's where that 12-month line is. So it's really only 0.1 of the 10 that meet the criteria.
Okay. Are there any, I don't even know what the word is, conditions or something that we had when we were younger? We were talking about endometriosis or cysts or tilted uteruses that we have been told by a doctor at some point in our teens or early stages of our 20s, and they said, oh, you're probably going to either have a hard time getting pregnant, probably going to have a hard pregnancy, you might not be able to ever get pregnant. Yeah. I mean, I've heard all of those. I'm sure you've heard those. Your thoughts on that?
So, I mean, my first snarky answer is please don't ever tell a teenager she can't get pregnant.
Yes, agreed.
I can't tell you how many patients I've taken care of who were told at some point in their youth by some doctor who doesn't do OBGYN that they would never have a baby. And then I'm taking care of her and her baby. Okay. If that's what she wanted, great.
Right. Yeah, exactly.
But I've had lots of them get surprised pregnant because they were told they didn't have to worry about it. Essentially, that's what she heard. I can have sex without worrying about a baby.
Because I'm never getting pregnant.
All kinds of crazy things. Like, I mean, one that holds a little more water is she got chemotherapy for something, in her prepubescent years, and they're pretty sure it would have ended her ovaries. And if she's indeed had to take hormones to go through puberty, I mean, probably that's probably correct. But if she got her periods on time and she did all the things we just talked about, the parts are there and they work.
So if she's still got all the parts,
I mean, we still just need to cover our bases, right? If she can't get pregnant one day when we get there, then we can cross that bridge. But, I don't want them having these false sense of security,
right? Or the stress of thinking I'm never getting pregnant.
Right. And that's the thing. I feel like a lot of times they're told that it's real off the cuff. And so I'm going to roll my eyes at my colleagues who are men and older and, because I feel like the generation before me just sort of dismissed a lot of things or blamed, like they didn't have a good answer. Like, why can't I get pregnant? Well, it's because your uterus is tilted. Why can't I get pregnant? Well, because you have endometriosis. Now, granted, endometriosis is a thing that can get in the way.
Okay. Can you surgically remove?
Yeah. I mean, there's a lot of things we can do to help. There's a minority of women that it's going to be so bad that we honestly can't fix it, and they still may need the fertility doctor's help. But endometriosis, that's more of hopefully what the doctor meant when they did their laparoscopy at age 18 and said, you might have trouble getting pregnant was, you have endometriosis and you might need a little help. what I tell my 18 to 20-year-olds when I diagnose them with this is if you're not trying to get pregnant, you need to be on birth control because it's the only way to prevent this from blocking up your tubes, mucking up your pelvis. It's a chronic inflammation in your pelvis.
Why does birth control help endometriosis?
Because endometriosis is fed by your ovarian cycle hormones.
Oh, okay.
So if we're not ovulating, which is how we don't get pregnant,
right,
we are also not growing the endometriosis tissue in the pelvis in places it does not belong.
Okay. So would you put most people who have endometriosis on the pill? Is that?
Oh yeah.
Okay.
I mean, I'm a big, I try to make it glaringly obvious that is the way to avoid future surgery because, I mean, there are patients out there who've had surgeries multiple times for endometriosis in their, yes. Yeah, until you're menopausal, something's always feeding it.
Okay.
Right?
Gotcha. As long as you're ovulating,
it slowly
it's feeding
accumulates in your pelvis, and then you eventually have pain again, and you have to go back to the doctor, and you have to have a surgery. And, I've had patients who are like, oh, I can't take birth control, it makes me sick, but you have endometriosis, let's find you something else. And because they said birth control, they probably meant pills, and really any birth control will better your chances. Yeah, and some are really good at it. Like an IUD, for instance, the progesterone kind of, for lack of a better word, I don't want to say flatlines, but it sort of mollifies those huge pulses of our hormones that feed a lot of things. Incidentally, that's where a lot of people's PMS and, other symptoms of the period that are not so fun come from. So if you mute those huge waves of hormone, you stop a lot of things. You prevent the ovulation so you don't get pregnant, but you prevent anything that goes with it. So feeding the endometriosis, the pain of a period gets better on birth control, right? You don't grow as much lining. That endometrium is the lining of the uterus. Yeah, pretty much any birth control limits the growth so that there's less that has to die and come out of you. The tissue death causes inflammation. Inflammation is a doctor for swelling, right? Everybody knows if their ankle is inflamed, it hurts. So if your uterus is inflamed, it hurts. If there's less that dies and comes out, there's less inflammation, there's less pain. And some birth controls, over time, their period just doesn't happen. Totally fine.
Okay. So now we've got pregnant.
Yeah. Okay, cool.
Let's just say we got pregnant. We did it within the 12-month window. Mm-hmm. We have had our baby. Mm-hmm. Have that baby. And one thing that I am a big kind of believer in is that there's so much information and knowledge and just like the Google highway of how to expect a baby, all these books, what to expect when you have a baby. And everything is just so idyllic and just dreamlike.
Sure.
And you are just doted over. Everyone tells you how amazing you look all the time. You have so much attention. You're just like the light of your husband's world, right?
You're talking about when you're pregnant.
When you're pregnant. Mm-hmm. And then you have the baby. Mm-hmm. And now it's almost like the baby is that. The baby is the light of everyone's world. Yeah. And
it's very cultural.
Yes. And it's almost like we as women are just, we've done all of this. It's taken us 9 months to get here.
We were the vessel for the grandchild.
We were just the vessel, right. And we're just expected to just bounce back and just be fine and heal emotionally and physically.
Yeah.
Realistically, physically. I know they say always 6 weeks.
Well,
what is realistically, are you healed?
Yeah, 6 weeks is your postpartum visit time frame. And honestly, there was a push for a while to make it 8 weeks. You're not 100% non-pregnant physiology by 6 weeks. Not at all. The bulk of your, felt recovery is probably done by then. But there's a lot of stuff happening in your body still trying to reverse for several more months. I don't think anyone can really put a line on it. At 12 weeks, you are finished. I think everybody varies a little bit. It also has to do with things like the breastfeeding physiology and, if people didn't versus if they did, some of that stuff. But the bulk of the physical recovery is the first 2 months, let's just say. Yeah. And some it's worse than others, right? If you had a very difficult vaginal delivery and you have a lot to recover from down there, you're going to need every bit of that whole 2 months. And
plus you're taking care of a baby.
Well, plus you're, and not sleeping.
Yeah.
Mm-hmm. Yeah, the not sleeping part is very key.
It's very,
because we could all, I talk about this with patients all the time. We could all do a lot more and feel like we're more together about it hard things if we just had more sleep.
Right.
Right.
Yes.
But you're having to do all of this, the recovery, the learning how to be a mom, the keeping the human alive.
Yep. Yeah.
You know,
you have a lot
with just at, 2-hour nap intervals for several weeks for a lot of people. And that's hard, especially if, right before that you were getting a lot of, new parents. I swear, I thought, oh, I'm never sleeping in ever again.
Yes.
Yeah,
I feel
before
like
a 6-hour night was a real bad night. After the baby sleeps 6 hours,
you can't ever imagine getting
I am a
sleep
new
again.
person.
Yeah.
I got 6 hours in a row. That's a major, that's a big change. So
that's the physical.
Yeah.
From the emotional point of it, talk to me a little bit about, you said it's not called postpartum. No,
Well,
it is still called postpartum depression.
It's officially called postpartum depression. It drives me crazy because it's not, people think, and they'll say no, no, I didn't, or no, I don't have that, because the conception is depression means I'm sad and I cry and I stare at a wall. Okay. And most women, that's not even close to what, they might be crying, but more often than not, it is a state of anxiety to the point of OCD. Obsessive compulsive disorder is a version of anxiety disorders, recognized as a psychiatric diagnosis. Postpartum depression is also a recognized psychiatric diagnosis, but it much more resembles anxiety and OCD tendencies than actual depression. Now, to some degree, most depressed patients have anxious symptoms. Most anxious patients have depressed type symptoms. They may all exist at the same time or back and forth. So maybe it's just the word we use to encompass the entire spectrum. I just find that most of my patients, again, because it's out there as this word, depression, that's not what they're feeling. They're amped. They're agitated. They are exhausted, but their brain won't stop spinning when they should be sleeping because the baby's finally sleeping. And I'm exhausted and I haven't slept in days, but I'm thinking about all the things I didn't get done, the things I need to get done.
Do they come to you and say, I'm not feeling well?
Some do.
Okay.
I think a lot of people, and this might be, I think it's missed a lot because we do the physical follow-up at 6 to 8 weeks.
Mm-hmm.
And for some women, it hasn't really manifested itself in all of its glory. It is probably there sort of at a low level in a lot of those women, whether they recognize it or not at that time. Now, some of them will come to that visit and just, they kind of turn into a puddle while they tell me what they're struggling with and how all their friends are so happy and I thought I would be happy and why am I not happy? And, and I'm there for it. I had it twice.
Yeah.
So
is it just not talked about enough in the before care?
I think it's very underdiagnosed, very, hush hush. I think a lot of our moms and grandmas just, they just got through it. Culturally it was, you don't talk about depression, your family wants to make you feel bad for taking medicine now.
Yeah. What is the medicine? Is that the treatment?
Well, that's one option. Therapy is another one. But I use that example all the time. Like if you had a heart condition, your family wouldn't talk you out of the medicine, right? And this is a neurotransmitter imbalance in your brain that has been, the scales have been tipped by other things that this person has no control over, and probably also a DNA tendency, also something this person has no control over. If it's in your tree, you're going to see it.
Yeah.
Probably.
Okay. Is it genetic?
At some point in your yeah. Depression, anxiety is definitely very mental health disorders.
Okay.
We'll just say on the whole can have it's very genetic. That's not to say you have it and no one else in your treated, so you're some weirdo. But
or that you'll get it because your mom got it.
Yeah. It's not an automatic for sure. Like my mother's, she got all the happy genes. She has, I'm pretty sure, never ever been close to depression or anxiety.
But then you had it.
But I had it twice.
Okay.
And but on her side of the family, there's some breadth of that. And I think my dad has a little bit of a melancholy side. I'm not sure I know as much about their whatever their diagnoses are, but it's in the tree. And I do also think it's a lot more, I've seen a lot of patients, I see myself in them. And for my own description, like a type A woman, if I do this, then this will happen. If I do the right things will happen. And postpartum is one of those times of your life, you could have done everything right. And it don't mean that everything's going to go right.
Yeah.
And you got zero control over that. And I don't do change my plan real well. And so for my own, I think because of the type of person I am and the way it was really difficult to feed my baby the first time, and family things bearing on me.
Did you feel like you couldn't talk about it?
No, and I was in med school. I had my first kid in med school and I knew about I remember questioning myself several times, like, do I have this? Do I not? There were always like circumstantial things I could sort of be like, but this is going on. I was finishing med school. My husband was finishing med school. Not med school. He was finishing his own grad school at the same time. We had just had a baby. We're moving across the country. Like, there was a lot of things going on that would stress anyone out, right? So for a while, I wasn't really sure that I had it or I didn't. And I would say my first time with postpartum depression was very subtle. More insidious, slow onset. Sneaky. And yeah, it wasn't like extreme.
Yeah. Which is kind of why you need your family members to also also watch out for your family members, your sister, your girlfriends.
And I mean, my mom and my sister-in-law at the time both felt like I had changed and kind of verbalized it. But ultimately it was at Air Force. I went from med school to active duty residency, and in some intake questionnaire, however I answered questions, flagged me for an interview. And whoever was my assigned PCP wanted to talk to me about it. And I was ready. I just spewed on her. I was just like, I think this is what it is, like, and so she put me on medicine. I was only on it for like a month. And it was mostly because it was hard for me to go wherever I was supposed to go to get my refill. And at that point, my baby's like 9 or 10 months old. And I'm thinking, I mean, I'm probably most of the way out of this.
Well, it probably just makes you a great doctor to recognize it in your own patients.
Well, and the second time it hit me like a brick wall.
Yeah.
And I had no reason. I mean, at that point, I didn't have all the stresses that I just, I'd rationalized the first time.
Right.
I had all these
this time it just
stresses.
came. Are you more likely to have it if you've had it once? Or you're more likely to have it again?
So for multiple reasons, if you're more likely to have it if you had it before. You're more likely to have it if you were undertreated. I was definitely undertreated. I only took the medicine for like a month, and the guidelines say take it for a year. Yeah, to minimize the chance of recurrence. So I was fine right up until I was not. After my second kid, 3 or 4 months, he's 3 or 4 months old, and I was a mess.
Oh, so how long did that last then?
I got on medicine pretty quickly, but they take 4 to 6 months weeks.
I was like, wow, that's a long time.
Misspoke. They take 4 to 6 weeks to kick in.
Okay.
Not kick in, but to fully do their thing. I would say most of us notice improvement probably in the second or third week of taking it, but you're not going to be to your maximal benefit on that dose until 4 to 6 weeks out. So there was a time where I was just waiting to feel better. And I just couldn't, it's like stupid things. Like I couldn't write a note in the chart about a patient. Like I'd just seen someone and I couldn't put my thoughts together, and then I'd stress about the fact that I couldn't write the note longer than it would have taken me to just write the stupid note.
Judging yourself.
Yeah. I'd look at a strip and be like, what if I don't act when that baby's in danger and something bad happens? I mean, you catastrophize for stuff that's never going to happen.
Well, and I think like as a mom, you're supposed to be able to do everything perfect. Sure. And so there's probably a lot of like an element of almost like, I can't believe I can't do this. And especially for you who's achieving all these other things in your life. And you're like, but wait, why can't I just do this one thing?
Yeah, I'm a highly functional person, I guess, whatever therapist is. Everyone should go to therapy.
Yeah.
But I was very disabled.
Yeah.
Like with just basic things. And I would just cry and call my mother. I mean, you're 30 years old crying to your mother. Like, why can't I stop crying?
Well, you'll be a great resource for people who are coming to you, who are coming in your office and they say, I can't stop crying.
I cracked a joke at a resident sign out like a month later, and they were like, You're Daniel's back. That's what they all said. And I was like, what? Was that noticeable?
Did you feel you were back?
I had gradually gotten there.
Okay.
But until they said it like that, I didn't realize how obvious it was.
To everybody else.
But they were just like, well, somebody said, she's back. And I was like, I am? And they were like, oh, yeah.
And then were you just back? Like that was just, once you were better, you were better?
Yeah, I mean, it probably, somewhere in that 4 to 6 week range, I had just gotten less and less, paralyzed with normal stuff. Yeah. And I never had, and this is common for a lot of women, it was never directed at my baby. The baby I wanted to be with the baby. I didn't really want to do anything else.
It was all about you.
Yeah. I just wanted, like I had no ill will toward my baby. Now some will, they'll be angry that the baby's crying again. And then they feel bad that they're angry. They just want to sleep, but they're supposed to take care of it. And they go through that whole, very few people get to the level of like, we talk about postpartum psychosis being those poor women you hear about on the news, who drowned their kids in a bathtub or drove the car into the lake with kids in the backseat. I mean, almost all of those women have a newborn. If you read the ages, there's one in there was an infant, and that's what it was. And that's very rare, thank God. But it's also very hard for people to realize is there when it's just scary how it can just kind of creep up and it's tragic. But most of us, it's much more related to everything else we had to deal with, and not the baby. The baby was the only solace I had.
Okay.
Yeah.
Not related to
And he was an
hormones?
easy baby.
Not related to hormones?
No.
You're going to say I hate hormones. Don't talk to me about hormones.
Well, it's got a little to do with it. I mean, you're hormonally,
hormonally fragile?
we'll say balance beam.
Okay.
Postpartum, you're on a balance beam. Your hormones were a certain way in pregnancy, and they are dramatically different really fast.
Okay. Would that, when you say a hormonal balance beam, would that be very similar to like what you are walking on in menopause?
Yeah, I use that analogy a lot too.
It seems like there's like this common theme that keeps happening with all these, like getting your period and then like the getting the pregnant, and all the time it's just like the hormones. And then it's like you finish that stage.
Well, people will be like, I'm hormonal.
Right. And you're like, what does that mean?
That's a paternalistic society thing you've been taught to say.
Right.
Ultimately, people, my hormones, I need my hormones checked. My hormones are wacky. My hormones are out of whack. My hormones are out of sync. I hear this all the time. And the basic answer is, well, if you have monthly periods, your hormones are doing exactly what they're supposed to do. Now, is it always pleasant when they are doing what they're supposed to do? No. Thank God we have things to do to optimize that for you. That is birth control and other things. But you
wouldn't put someone on birth control in menopause though. That doesn't fix things, does it?
It's a lower level hormone replacement. So you don't need birth control. Your ovaries aren't making eggs. Okay. So we don't have to suppress ovulation, but we are trying to bring the void up a little. You get your symptoms. This is postpartum and menopause kind of have similarities here, where it's the dramatic drop in hormones that makes us feel all the things.
Okay. So that's what menopause is essentially.
Your hormonal levels are so much lower than they were recently. And the longer I do this, I mean, my analogy that I use for patients is, so the girls, there's always a girl in a group of friends who will sort of just listen to everybody's crazy menopause stories and not really volunteer too much because hers hasn't been that bad.
She doesn't want to tell you.
And probably she knows better than to say, well, it's really,
I've enjoyed it.
It's not so bad.
Yeah.
I had a few hot flashes. And they tell me, like, and I go, I'm a clap for you. You tell me all day long, don't tell your friends. Because the majority, it's been much more dramatic. And the difference is, so if your ovaries quit one day, that's a little bit like jumping off a cliff. And the other girl, she rolled down a hill.
Gently. Just gently. Just right into the field.
You can survive the other one. Jumping off a cliff is pretty scary. And so that hormonal carpet being ripped out from under you, your body doesn't adjust well. It doesn't have time to adjust.
Is that normal for menopause? That it just
It's DNA. Some of us, it just quits. The ovaries were like basically punching out eggs right up until they couldn't. And then other girls, it's like their ovaries went like, well, I can't make eggs anymore, but I can do this. And so they still have estrogen in there. Like they'll tell me they haven't had a period in 8, 9, 10 months, but they haven't had that many hot flashes, right? So their ovaries are still doing something.
So that's not menopause. If your ovaries are still doing something?
Nope. Menopause is 12 months.
Okay.
Officially, menopause is 12 months without a period.
So if you...
At the right age.
Okay, what age
you're
would that be?
Well, if you're 25 and
you're not in menopause.
I'm like, let's figure this out for you. That doesn't seem right. But if you're, the average age is 51 in this country. It's different, I think, in different parts of the world based on, again, ethnic, DNA differences, but going to be basically the same range.
Yeah.
Give or take a few years.
Is your first sign of menopause that you don't get a period?
No, not necessarily.
Okay.
A lot of women start to experience more dramatic PMS years before their periods get wacky, right? So again, that hormonal nosedive is happening, like we ovulated and we're done. And so that week into the period is like, whew, like where'd my hormones go? Because your ovaries, it was all they could do to get the egg out. They can't do it anymore.
I'm going to read you something.
Okay.
And this was, so I am not in menopause yet, but I'm probably not far off. And so, of course, I have been Googling like a crazy person for like the past 6 months. So this is what Dr. Google says.
Okay.
Are all the things that I can look forward to as a menopausal woman.
I think as a general Dr. Google question, you're probably going to have come up with mostly the right thing.
Okay. And you can tell me if I've left anything out.
Okay.
I'm actually just hoping you're going to tell me half of them are wrong. Hot flashes, night sweats, loss of sex drive, vaginal dryness, feeling the need to urinate, insomnia, mood swings, depression, irritability, dry skin, dry eyes, dry mouth.
So the answer is yes. Any of those, probably not all of them for every woman.
Right.
It's kind of like all the things you read on the back of like you buy medicine over the counter and it says,
possible symptoms.
all the possible side effects.
Okay.
Basically, every time they study a medicine, they have to list, once they get released, they have to list everything the patients in the studies complained about.
Okay.
Now, there are a lot of things in that list that are common and some that are less common.
Gotcha.
There's also a range. Some of them you experience more so at the beginning of menopause and others that might not bother you until much later.
Right. So I was laughing with a girlfriend of mine because it was actually when I was on my way to when I found out I had a fibroid. Mm-hmm. And before I came to my appointment, I was Googling, I was like, God, am I in menopause? Like, what's happening? And like the first thing that came up, and her and I were laughing so hard. I mean, not in a good way, but I was like, my gosh, it says like one of the things is vaginal atrophy. I'm like, do you know what that means? That means like death, dead. Like it just dies. And she was laughing so hard because she was like, I mean, do you think they could have given us a better word? Because I would like to think that that's not really the case. That, you go through all this stuff as a woman and then it just dies. Like
the vagina didn't die.
It's just done.
No.
It's just done. So it doesn't actually die.
No.
Atrophy? What does that mean though?
It means that hormonally responsive tissues only react to hormones being present. Okay. So when you have vaginal skin and then you have tissue that responds to hormones. So basically the lining of the vagina.
On the inside.
Mm-hmm,
yeah.
That's what we call mucous membrane. So stuff on like the inside of your cheek.
Right.
It is mostly responsive to hormones. There's some of that function is going to stay beyond hormonal effect, but a lot of it changes when the hormonal cycle is no longer present. It doesn't go away immediately. But I'm just going to get detailed. A healthy vagina has a lot of potential stretch capability. I mean, a human can come out of there.
Right. Yes.
So there's a lot of extra tissue folds. There's stretchiness, there's lubrication, and that also requires a level of thickness of the tissue to be able to do all of that. When a vagina is atrophic, it has lost those layers of thickness, the elasticity, and a lot of the lubrication. And so, you're not going to get a human out of that size vagina.
Right. Which is why you cannot get pregnant.
Well, sure.
In menopause.
Obviously, we lose the pregnancy ability first.
Right.
So that things happen in the right order. But there are, now we're living a third of our life beyond menopause. Okay. So back in the day, I use prairie analogies a lot for my patients. You might die shortly after menopause. Well, back in the day, by the wagons.
Because your body was no longer needed to reproduce?
They didn't have great nutrition and all that other jazz, right? So life expectancy, all I'm saying is they didn't live that much longer.
Right.
On
now we're living a lot longer.
Right.
Women are living a lot longer.
A third of their life in menopause, okay? They used to only be inside of a decade probably, right? Okay, so that's a big difference. And our partners are living longer too, and they want to have sex. Okay, so the vagina... The postmenopausal vagina isn't that accommodating. So that's where some of this, the sexual issues can come up in menopause. Now, there finally are some medicines.
Okay. Such as?
Well, my favorite is Osphena.
What's that?
So it's ospemifene, which, if you look at drug names, that makes it related to a more widely known medicine, tamoxifen.
Okay.
That is a medicine a lot of girls on, that's post-breast cancer treatment.
Okay.
Big difference, but in the same class. So the class of medication is called a selective estrogen receptor modulator. It means it's only been engineered to talk to these estrogen receptors in this part of the body. Furthermore, it can be engineered to either inhibit said receptors, that would be tamoxifen in the breast. We want to stop estrogen from growing a cancer in the breast.
Okay.
Or to activate estrogen receptors. That would be Osphena in the vagina.
Okay. Which is what you would want.
Yes.
Okay.
So it is a non-hormonal, right? So it's a pill that they take every day and it just talks to the vagina. doesn't come with all the hormonal, risks, the hormone therapy risks.
The hormone therapy.
Right?
Okay,
Which,
I was going to ask you.
I know I said I don't like hormonal as a word, but there are some risks when we talk about hormone replacement therapy and menopause, and we have to talk about those when patients are considering what do we need to use for treatment for your symptoms. Depends on the symptoms.
Okay. Does the pill take care of the other kind of symptoms, like the night sweats and that kind of stuff, or just the physical
That
issues?
pill is only for vaginas.
Oh, okay.
Okay.
Got it. So
we said we were going to talk about
So
vaginas.
you have a pill for your vagina.
Yeah.
Now you need something for your, all these.
So let's talk about the spectrum, though. Remember how I said some are early onset and some are later, right?
This is depressing.
So
I think I might have postpartum depression after this podcast. I have postmenopause depression.
Well, that's
definitely.
interesting. So did that come on your list? Because there is a group of women who will either feel like they're depressed or may also have coincidental depression around the time they're going through menopause.
Yeah.
Some of it's just emotional volatility related to the hormonal, change. It was too dramatic and it's involved. And others, it's a both and. Chicken or the egg. Not like, menopause makes everyone depressed.
But I think I could see it also being a mental, like the thought of this is
now I'm old.
Yeah.
Yeah.
Or
totally.
It's kind of like the last, of all the stages we've talked about today.
Yeah. Well, now I'm at the end.
This is it. What's next? We die? That's this. I have nothing left on my list. We're done talking about this stuff.
No, you have a third of your life yet to live.
Exactly.
Okay.
But I guess that's my point is that women are they've known their cycles from getting their periods and then getting pregnant. And I even remember after I had my last and I had my tubes tied and I knew she was my last, I did not want any more. There was not any part of me that wished I hadn't done it. But when I was in the hospital recovering from that, I felt such immense sadness. And I remember John being like, what's wrong with you?
Yeah.
He's like, is this postpartum? I'm like, I don't think it comes on this quick. It's been 3 hours. But I remember standing in the bathroom and thinking, this is the last time I will do this. This chapter of my life has closed.
Sure.
And I don't know, I had such a sadness about it, even though I didn't want more kids. Mm-hmm. But so I can imagine how once you hit that menopause phase, you kind of feel like there's nothing left after this in terms of, you're always looking, well, next is going to be this. Next, I'll get pregnant. Oh, I still have to go through menopause. Right. And now you're like,
yeah.
And it's it almost seems like it would be more fair to go through menopause and get all this amazing stuff that happened versus.
Mm-hmm. Well, you don't have to worry about getting pregnant anymore.
Yeah, but I had my tubes tied. I haven't worried about that.
But I do have women really looking forward to that. They're like, oh, you mean I don't have to take this birth control anymore?
So what can we be doing for the hot flashes, sleeping, mental, anything like that?
And I would say, so earlier in menopause is when more people are going to experience hot flashes, night sweats. Those are what we call vasomotor symptoms related to the more recent loss of the estrogen stability we had. Okay. I would say night sweats often show up first, probably because most of us, our circadian rhythms, dictate that as we sleep, our temperature gets to its highest point. That's a normal kind of thing. And the thing is, without the estrogen, we've lost the as reliable ability to temperature regulate. And so it's like a switch is flipped and we can't deal. So a lot of women start waking up, their hot flashes at night are the night sweats, the first maybe symptom. Or earlier symptom. Plenty of people also are going to start experiencing the hot flashes during the day. They can be very sporadic at first. Like I said, they can often be first, it's a PMS symptom and it's only happening in that week right before your period when your hormones are lowest. Then it gets better as you go toward your next egg. Mm-hmm. And then, you might start skipping some periods and having more symptoms on more days of the month. There are others who swear to me they never really had any hot flashes or night sweats until long after the periods were gone. And that's more of a gradual, I guess, decline. A little easier to do. But those are by and large, and the mood instability. Yeah. Irritability is a common complaint. They're just like they snap at somebody and then they feel really bad about snapping.
Right.
Like, why did I say that? Kids, husbands, work colleagues, I've heard it all. My husband's going to leave me. I'm going to get fired. And my son said he's not coming home until I get on something. I've heard all of that.
So what would you put someone like that on?
Well, if you're experiencing all of it dramatically, probably the only thing that's going to make you feel better right now is some hormone. Okay. So, and when we talk about the Women's Health Initiative, which is the study that everybody, sort of got about hormone replacement from, my patients are much younger than the average woman in that study. Furthermore, they were giving everyone hormone replacement because we thought it was like the fountain of youth. It was going to prevent all these things. Turned out it was killing people. And I'm oversimplifying this, but the average age of those women, bottom line, was 65. And I'm talking to women who are 50. Okay, that's 15 years. They're a lot younger and healthier at that point in their life. Plus, we were just ovulating a few months ago. Right.
Okay.
It's not, somebody who comes and wants to start hormone replacement at 60 gives me pause, because if she had menopause on average when everyone else did, what's the issue now?
Right.
Right. It may not be
because
the right answer.
How long are you having? Like, do you just have menopausal symptoms till you die?
Well, some.
Gosh. This is terrible news.
I think so on average, let's say if you asked an 85-year-old woman if she still has hot flashes, she would say occasionally. Okay. But they don't run her life like they do in our 50s, let's say, for a few months or a few years if you don't take anything. There are non-hormonal things that can help people with, say, the milder symptoms if they don't have all of them terribly.
That are like doctor prescribed?
Prescribed and non-prescribed.
Okay.
I mean, we can just throw it out there. There's something called Relizin. It's a Swedish flower pollen extract that came over from Europe 5+ years ago. I can't remember exactly when. But they'd had it over there at the time for 20 some years. And it took a while to get our FDA approval thing here. And it is over the counter as a supplement available to anyone who gets on the website and orders it.
Okay. But not like in the pharmacy.
No.
You'd have to order it.
They don't have it in the stores. You can't get it on Amazon. You got to get it from the company that got the right to distribute. So it's Bonafide is the medical company. So they also have a PMS version. It's just kind of more of the same ingredient, and some royal jelly, which is another naturopathic thing for PMS. So that's called Serenol. So there's 2 products there already non-hormonally addressing some of the symptoms. Fine for pretty much anyone to try. Maximal benefit, you got to take it every day for 3 months. So I have various patients that'll go that route for a while. Sometimes we're also using that. They've been on hormones for a while, and maybe it's time for us to think about coming off. And I'll give them this or suggest they try this as we back off on the hormones. Because there's no reason for us to just go, I never recommend somebody stop their hormones cold turkey. Because it's going to feel like menopause would. You just pulled the carpet out. That's unpleasant. Jump off the cliff. We don't want to do that.
Right.
So we need to recreate the rolling down a hill. Now I'm just going to gradually dial down on your hormone replacement prescription so that your body gets some time to adjust more slowly.
So it's definitely something you should work with your doctor.
Totally. It's very individualized.
For all your options.
Because what's your family risk factors?
Right.
What's your personal? If you had breast cancer, I can't give you hormones.
Okay.
So then we got to focus on, well, what else can you take?
So versus going on, or even I think probably 2 people ask their friends, oh, well, this worked for her. Oh, I'll order some of that. But it's probably best to see your doctor.
Probably. And because everybody's constellation of symptoms are slightly different,
Mm-hmm.
And the global symptoms need to be addressed a different way than the vaginal ones. The vaginal ones are usually coming later in the process when the hormone has been lower or gone for a while. And that would depend on, did she take any hormones? Did she not take any hormones, right? And age and stage is one thing, but is her husband even alive? Does she need to have sex, right? I'm not saying your husband has to be alive to have sex. There are some women who, they have another partner later.
Listen,
that's all I'm saying.
That last third of your life, you could just take on a whole new path.
Totally. So if the vagina needs to be used, or a better word, accommodating. I don't know how much better that word is, really.
Who says that word?
Yeah.
I don't know.
Youthful? Shall we say?
So this what all the vaginal rejuvenation surgeries are about?
I hate that. I hate that one too.
You hate the word or the surgery?
So surgery is a strong word too. My understanding is they're doing, it's injections.
Okay.
There is some vaginal.
I think you can have it chopped up
there
now
is some
and put back together.
Yes. Well, to make it tighter.
Yeah. You're going to give that a no?
There are people who do it. The question is what rejuvenation is. There are some people who just want it to look pretty, right? That's a plastic surgery realm, post-baby, post-whatever. I lost a ton of weight, make it look nice. But, surgery causes scars, so it doesn't mean it's always going to feel perfect.
You don't know
later.
what's going to happen.
There's a calculated risk there. Injections and things to make it tighter on the inside without surgically scarring things. Okay. That's all. I would put that all under the cosmetic realm. I would not put that in any kind of medical
No one's going to
category.
tell, you're not having that for menopause. That's just its own.
You could.
Yeah.
You could choose to go that route, but plumping up a vagina that doesn't have the right lubricative, healthy tissue in there, I don't think is going to achieve the desired result.
Plumping up the vagina is not an expression I thought I was going to hear today. But you know what? You can plump up everything else. So
I know. Turns out hyaluronic acid supplements for your face, you can do that for your vagina too.
I mean, on that note, I could sit here and ask you questions all day long on so many things. And I feel like even, especially like with menopause, there's so much more to unpack. And I'm thankful that you were here today. And there's so much information out there, and especially with the world of Google now and TikTok and people talking to their friends. And I hope this really kind of gave just the nuts and bolts of kind of the hot topics out there that people could take away from and
really give them stuff to ask their doctor about.
Ask your doctor. And, maybe we will have you back if you would come and talk more in depth about maybe menopause.
Yeah, whichever.
Maybe when I get there and have so many more questions, I'll be in here. I'll need like a fan at my side.
Well, we kind of skipped over pregnancy too. You might get some questions about that from your younger audience.
Yeah, we can do a whole thing on the pregnancy and menopause. Sure. Two favorite. Well, thank you for being here. I appreciate it.
Thanks for having me. It was fun.
Thanks.